Topic is opposite of hyperglycemia, that is hypoglycemic episode.
So any textbook of diabetes is incomplete without a chapter on hypoglycemia. So similarly, any conference on diabetes is also incomplete without a discussion on hypoglycemia. That's why we are going to discuss about hypoglycemia today. So this picture is taken from a very old textbook written by Robert H. Williams, where he particularly mentioned that this textbook included a topic on hypoglycemia. So the first topic was itself on hypoglycemia. In those days, they call it as hypoglycemia. And he was describing very well about hypoglycemia in this textbook. So this is a very important picture where all junior doctors should concentrate. So insulin is one of the important metabolic hormone in our body. And this is so important hormone that it has lot of enemies. So you can see that in this picture, insulin is depicted as a coolie. So imagine in our recent picture by Rajinikanth, he was a coolie there and he had lot of enemies. So likewise, insulin in our body has lot of enemies, particularly these four enemies like growth hormone, epinephrine, glucagon, and hydrocortisone. These are the four major antagonists or enemies to our insulin. So the insulin tries to put all the glucose into the cell in order to generate energy. So at the same time, these enemy hormones, particularly these four hormones, try to push out all the insulin into the bloodstream so that they make high blood sugar levels in the patient's blood. So on other side, whenever the patient consumes more glucose, again the blood sugar remains high. The insulin has to be very active to push the glucose into the cell. So the other important enemy which our insulin has is the insulinase, which is a hormone that degrades insulin. So this is the thing which happens in all our body. Whenever there is an imbalance between this insulin level and the counter hormone or this antagonist hormone level, there is an alteration in the blood sugar level. Suppose if the insulin levels are very high and all these enemies are very weak, patient will land up in hypoglycemia because it will push all the glucose into the cells. Suppose if the insulin levels are very low and if the counter hormone levels are very high, all the glucose come into the bloodstream and the patient has hyperglycemia. So this has to be understood very clearly. And in those days, hypoglycemia, there was no proper definition was given. It was only arbitrary based on the symptoms. So whenever the blood sugar levels came around 70 or 72, the autonomic symptoms developed because of the activation of the autonomic system. The patient developed palpitations, sweating, hunger, and all those things. And when the blood sugar level gradually decreased to 54 and less than 40, the patient develops cognitive symptoms like disorientation, giddiness, and lack of awareness around the surroundings. So all these things can happen. But when the patient develops severe hypoglycemia, like when the blood sugar levels drop below 20 milligrams or 18 milligrams, the patient will end up in coma. Later on, the American Diabetes Association gave the clear-cut definition of what is hypoglycemia. So any blood sugar level less than 70, we call it as hypoglycemia. Again, it can be classified into three levels. Level 1, where the blood sugar levels are between 70 to 54, and level 2, when the blood sugar levels are less than 54, and level 3, very low blood sugar levels, which requires assistance to recover from hypoglycemia. And this is another important picture taken from that first textbook of Robert Williams. Sorry for the poor quality of the picture. So this picture has two divisions. One is the glucose homeostasis in normal individuals, and what happens in hypoglycemia is depicted in the next picture. So whenever we take a normal human being where he takes normal balanced food, some amount of carbohydrate is converted into glucose and it goes into the bloodstream. So this is the level of blood glucose that is mentioned in this bar. So similarly, when the all the metabolic system is correctly functioning and the homeostasis is maintained, some amount of glucose is released from the liver that also contributes to the glucose level in the blood. And this release of glucose from the blood is also mediated by the glucagon hormone that comes from the alpha cells, and also pituitary through its growth hormone and through its effect on adrenals sends some signals to the liver through various hormones like cortisol and catecholamines and release the glucose into the bloodstream. Particularly, this happens in the night time, which is called as nocturnal hepatic glucose output to maintain the blood sugar level during the night times. So this is the normal physiological thing that is happening in our body. So whenever the blood sugar levels are maintained, the brain gets adequate blood supply and as well as adequate glucose level. So glucose is a very, very essential element to maintain the brain function. Brain is very sensitive to hypoglycemia. Whenever the patient blood sugar drops to very low, the brain cells start dying. So that's why hypoglycemia is a very important complication which has to be talked about. So in other ways, other tissues like muscles, liver, and other tissues of our body get glucose regularly through various mechanisms when the blood sugar levels are in the euglycemic state. So what happens in hypoglycemia? So there are multiple reasons for hypoglycemia, starting from low intake, low carbohydrate, liver failure, and alpha cell deficiency. Alpha cell deficiency, there is less glucagon, so less glucose output from the liver. And similarly, pituitary disease leading to lesser secretion of ACTH, and Addison's disease or any other disease that is going to affect the adrenal gland, there is lesser secretion of catecholamines. So again, there is lesser release of glucose from the liver during the night time. So that results in nocturnal hypoglycemia. So similarly, whenever the blood sugar levels drops below, drops below 54 or 40, the brain does not get the necessary glucose and lands up in complications. So what are the risk factors for severe hypoglycemia? So the first and foremost is the intensive insulin therapy. Now we have modern insulins and ultra long-acting insulin analogs like degludec and U300 glargine, which are very much useful in clinical practice to avoid hypoglycemia. In those days, we had NPH and other insulins where severe hypoglycemia was very, very common during that days. And trying to maintain near normoglycemia itself is also going to be a risk factor for severe hypoglycemia. So particularly patients who come to us, particularly elderly people after 65 or 70, they come to us and tell that, sir, my fasting blood sugar is 120, whereas in the lab reference it is given only 100. So I have to still reduce. So those are the patients who are going for hypoglycemia. So you clearly explain the patient based on your age, having 120 or 140 itself is normal. Don't try to achieve whatever given as a normal in the lab report. And a previous history of severe hypoglycemia, definitely hypoglycemia begets hypoglycemia. If you read the textbook of Harrison, the terminology will be given. Hypoglycemia begets hypoglycemia. So one episode of severe hypoglycemia, that is itself is a risk factor for subsequent hypoglycemia. And again, sleep, prolonged sleeping during nighttime in a patient who is having multiple doses of insulin, again is a risk factor for hypoglycemia. Long duration of diabetes and having autonomic dysfunction is again is a reason for severe hypoglycemia. And irregular lifestyle, taking insulin in the morning and skipping the meals, again, that will land up in hypoglycemia. Particularly in patients who are shift workers, the patient will come very late to the home, does not take any tablet, sleeps and take full meals and take another tablet in the daytime. Again, erratic lifestyle that will land up in hypoglycemia. And the next important is the alcoholism and binge drinking can also land up in hypoglycemia. And next is the increasing age. So as I told you earlier, whenever the patient age increases, the metabolism decreases and the requirement for drugs, particularly sulfonylureas and other drugs like insulin, comes down. So you have to gradually reduce the dose of drug depending on the age of the patient in order to avoid severe hypoglycemia. And special groups of patients, particularly pregnant ladies and adolescents who are on insulin, are at risk of severe hypoglycemia. Proper patient education has to be done in order to avoid severe hypoglycemia. Moving on to the symptomatology of hypoglycemia, it can be divided into two, the adrenergic symptoms and the neuroglycopenic symptoms. So the adrenergic symptoms are related to the rate of fall of blood glucose level, and it presents with tremors, shaking, palpitation, and sweating. These are the warning symptoms. If you educate very well the patient about these warning symptoms, he can come out of severe hypoglycemia. Whenever the warning symptoms occur, he will go and take some snacks or some drink which has sugar. And neuroglycopenic symptoms are related to the absolute level of blood glucose level. Whenever the blood glucose levels are less than 54, the patients can develop confusions, convulsions, and coma. So the brain is more sensitive to this low blood sugar level, and that's why the neuroglycopenic symptoms are more severe in patients who developed lesser glucose levels like 40, 30, 20 and all. So the autonomic symptoms include sweating, palpitation, shaking, and hunger. Neuroglycopenic symptoms include confusions, drowsiness, very odd behavior, speech difficulties, incoordination can also be due to this neuroglycopenia. In general, some patients will complain of headache, nausea. That could be also a symptom of hypoglycemia. So in your day-to-day clinical practice, you can ask your patients about unusual headache during the meal time. So most of the patients will complain, sir, 12 மணி ஆச்சுனா 1 மணி ஆச்சுனா headache வருது. So at that time, you ask the patient to check the blood sugar level, definitely it will be low. So hypoglycemia is a common cause for headache. So we think that it could be migraine or some other thing, but in a patient with diabetes on sulfonylureas or on short-acting insulin, headache during the noon time, particularly lunch time, is because of hypoglycemia. And most of the time in patients with type 1 diabetes, the symptoms of hypoglycemia are non-specific. Sometimes the patient will complain of only sweating, only headache, only double vision. So like that, symptoms are non-specific, but it will be stereotyped in an individual case. For example, if a patient develops double vision, every time whenever he develops hypoglycemia, he will have double vision. Sometimes if the patient develops headache, every time whenever he develops hypoglycemia, he will have headache only. No other symptoms will come. Symptoms of hypoglycemia are non-specific in type 1, but they are stereotyped. Stereotype means same symptoms occurs every time. So this is the thing that a hypoglycemic type 1 diabetes patient can visualize. So the brain is very sensitive to hypoglycemia. Brain is susceptible to neuroglycopenia in a rostrocaudal direction. So the cerebral cortex are affected first, followed by the hippocampus, then only the brainstem and spinal cord. But brainstem and spinal cord are mostly resistant to hypoglycemia. So this is the way it is affected. First cerebral cortex, hippocampus, followed by basal ganglia, and then only brainstem and spinal cord. So what happens in the brain? There is a depletion of ATP whenever there is low blood sugar level. Membrane depolarization occurs, lot of calcium enters into the cell, and there is excess release of glutamate mediators. That is that increases the excitotoxicity that results in convulsions. So whenever you see a patient in emergency ward with hypoglycemia, blood sugar level less than 40, develops seizure, that is because of this excess glutamate release. Not only this excess glutamate release, there is more oxidative stress that occurs during hypoglycemia, and mitochondrial damage can occur during repeated hypoglycemia that may lead to permanent tissue damage. So the cognitive dysfunction can also occur in patients who have severe hypoglycemia that can lead to impaired attention and executive function. Particularly, these things happen in repeated hypoglycemia. So if a patient has repeated hypoglycemia, all these cognitive dysfunction can occur. Reduced processing speed, memory deficits, all are very common, particularly in elderly people after 60, when they had 4 or 5 episodes of severe hypoglycemia, admitted, discharge, admission, discharge. Finally, they will come with cognitive dysfunction. And more important syndrome, this is the HAF syndrome, which is called as hypoglycemia-associated autonomic failure. And this is also very common in patients who have long-standing diabetes on sulfonylureas and insulin, very common. If the patient has autonomic dysfunction, they do not sense the hypoglycemia. Like we discussed in the first few slides, the adrenergic symptoms does not occur in this patient. So they do not recognize that they go for hypoglycemia. They go for very severe hypoglycemia because of this unawareness of the symptoms. So this severe hypoglycemia again worsens the autonomic failure. So because of the worsening of autonomic failure, again the patient lands up in hypoglycemia, which is called as hypoglycemic unawareness. And this becomes a vicious cycle. Once becoming severe hypoglycemia, worsening of autonomic dysfunction, again hypoglycemia, again worsening of autonomic function. So this vicious cycle is called as hypoglycemia associated autonomic failure. And this HAF syndrome can be easily reversible if we avoid hypoglycemia strictly for 2 to 3 weeks. 2 to 3 weeks, you avoid hypoglycemia. Keep the blood sugar in the range of 120 to 180. By any means, you can very well reverse this condition. Seizures and epilepsy, as I told, because of the increase in excitatory mediators, seizures are very common, and severe neuroglycopenia can provoke generalized tonic-clonic seizures, and repeated episodes of hypoglycemia can lower the seizure threshold also. So once the patient develops repeated hypoglycemia, the seizure episodes can occur repeatedly. Stroke-like syndrome. Generally, some of the patients will come to our emergency with stroke-like syndromes, but if you check the blood sugar, it will be around 40 or 50. And stroke, this hypoglycemia can mimic ischemic stroke. And recurrent episodes of hypoglycemia can worsen the outcomes in patients who have pre-existing stroke also. So that's why in patients with cerebrovascular accidents, we try to maintain the blood sugar levels between 140 to 180 only. Always 140 to 180 will be a safer zone for patients who had pre-existing stroke. And risk of dementia and neurodegeneration also increases in patients who have repeated hypoglycemias. So in a nutshell, hypoglycemic encephalopathy can be classified into two. That is, one is acute encephalopathy and next one is the chronic encephalopathy. So in the acute encephalopathy, patients can present with convulsions or hypoglycemic hemiplegia or focal neurological syndromes are also very common. So the patient can present with perioral numbness or perioral twitchings that are also very common in patients with acute hypoglycemia. And psychologically, patient can show mental slowness, inappropriate behavior in the common places, and aggressive behavior, very, very common. Patient with type 1 diabetes, when they become hypoglycemic, they behave very aggressively. Particularly, we have seen in our wards when the patient admitted and given insulin, hypoglycemia, patient will behave aggressively with the ward staff and all. And chronic during chronic hypoglycemic encephalopathy, patient can present in a vegetative state. Sometimes hemiparesis can occur, and sometimes motor and sensory abnormalities can be there, and other syndromes like ataxia, chorioathetosis can be seen. And psychologically, cognitive impairment is very common in patients who have chronic hypoglycemic encephalopathy. So effects of hypoglycemia on cardiovascular system. So generally when a patient develops hypoglycemia, the heart rate increases, systolic BP increases, diastolic BP decreases, and this will increase the workload on the heart. If the patient has a normal heart, then we need not worry about it. But if the patient has underlying CAD, pre-existing atherosclerotic cardiovascular disease, the patient can land up in myocardial infarction, which could be very silent and asymptomatic also. So effect of hypoglycemia on microvascular complication. Definitely all the microvascular complications like retinopathy and nephropathy are going to worsen during hypoglycemia, particularly if the patient is having proliferative diabetic retinopathy, vitreous hemorrhages can occur during hypoglycemia. And mortality, the more important doubt about hypoglycemia is whether the patient dies during hypoglycemia. It is very uncommon considering the extreme frequency of hypoglycemia in our day-to-day practice. Sudden death is very, very rare because of hypoglycemia. So it may be happening in some patients with very high doses of insulin, particularly in type 1 diabetes, or elderly patient with type 2 diabetes developing hypoglycemia because of higher dose of insulin or combination of sulfonylurea and higher dose of insulin. Very rarely it can occur in those conditions only. So hypoglycemia causing dead in bed syndrome can be of two types. One is undisturbed bed and other is disturbed bed. Undisturbed bed, it is not due to hypoglycemia, maybe because of cardiac arrest. Disturbed bed indicates that the patient has gone for hypoglycemia, developed seizures, and then died. So hypoglycemia has certain differences between the inducing factor, whether it is induced by oral drugs or whether it is induced by insulin. So insulin-induced hypoglycemia is predictable and it quickly responds because we know the time duration of action of the particular insulin that has been injected. Whereas with oral drugs, particularly with oral drugs, old drugs like glibenclamide or chlorpropamide, very long-acting agent, the patient will have repeated hypoglycemias even after correction. So that's why when a patient has developed hypoglycemia because of sulfonylurea, it is better to admit the patient and keep on continuous glucose monitoring as well as cardiac monitoring, because hypoglycemia with these drugs can trigger cardiac arrhythmias also. And one clinical point with regards to acarbose inducing hypoglycemia, you have to use only glucose in order to correct acarbose induced hypoglycemia, because if you are going to give complex sugars, again, that will be acted upon by this acarbose. Sometimes with older sulfonylureas like glibenclamide and other drugs, the hypoglycemia can be long lasting, maybe up to 1 week, because of the intrinsic action of the drug that has already bound to the beta cells. And hypoglycemia occurring in a patient who is routinely seeing you for years together, patient will be coming to you, but suddenly he will land up in hypoglycemia. That will signal the onset of remission. Probably in early days, remission is possible, but in long-standing diabetes, it is not possible. In long-standing diabetes, you think about renal failure and check the renal parameters. And in patients with gestational diabetes, the patient is landing up in hypoglycemia. It means there is impending delivery or the fetus is at risk. So think about that. And suddenly in a patient with gestational diabetes, if the insulin requirement is also coming down, think about the fetus is at risk. So risk of nocturnal hypoglycemia. A few words about nocturnal hypoglycemia. When the blood glucose is less than 100 or 108 at around 11 p.m., that is post-dinner blood sugar, the risk of nocturnal hypoglycemia is very high. And bedtime blood sugar predicts early night, but not early morning hypoglycemia. Okay. And fasting plasma glucose less than 100 indicates preceding early morning hypoglycemia. So these are the things which are written in the older textbooks. But nowadays, with the advent of continuous glucose monitoring, which depicts each and every moment of blood sugar movement, we can have a better idea of what happens during the night time. And moving on to what is called as hypoglycemic unawareness. This is mainly because of the autonomic neuropathy, and because we get autonomic symptoms whenever we develop hypoglycemia. But in patients with autonomic neuropathy, these warning symptoms are not there, and that's why the patient develops severe hypoglycemia. So this is called as hypoglycemic unawareness, and it is very common in patients who have long duration of diabetes, elderly age group, and again autonomic neuropathy, tight glycemic control, and in patients who are on beta blockers, because the sweating and other beta adrenergic symptoms are abolished in patients who are on beta blockers. So now how to treat this hypoglycemic coma? So a patient with mild to moderate hypoglycemia, you know how to treat. It's very common, and you can treat with the oral glucose or oral sugar solutions when the patient comes with a conscious level. But if the patient is unconscious and brought in a comatose state, blood sugar level is in the range of 20 to 40 milligrams percentage. You start IV dextrose infusion, whether it could be either 50% glucose or 25% glucose 100 ml. So you give a start dose, wait for 15 minutes. If the patient is not recovering, again give the next dose. So generally the patient will recover within 2 doses. And if the patient, you ask the history when the patient was last seen conscious. If it is long duration, then you can directly give a glucagon injection 1 milligram as a IM injection. So glucagon injection will try to push all the glucose that is there in the liver. So there will be glycogenolysis in the liver, and it will push the glucose into the system so that the patient's blood sugar will rise and become conscious. And this glucagon injection is not useful for chronic hypoglycemia. Patient is there in hospital for 3 or 4 days with hypoglycemia, coma. If you are going to give glucagon injection, it is not going to work. And in patients who have developed hypoglycemia because of liver failure, and again, it is not going to be useful. In patient who has consumed lot of alcohol and depleted all his glycogen in the liver already, land up in hypoglycemia. If you are going to give glucagon, it is not going to work. And if the patient is having irreversible coma, think about other causes of deep coma like poisoning, alcoholism, and intracranial catastrophes like bleeding or infection. Go with other investigations like CT brain and other advanced investigations. And on other side, you try to reduce the cerebral edema with anti-edema measures like mannitol or dexamethasone. So it's very common to have pet dogs at home. So the pet dogs are more sensitive and they understand their masters. So in the same way, if you're if a type 1 patient is having a pet dog at home and the patient is known to develop hypoglycemia at frequent events, the pet dog used to sense this hypoglycemia and alert its master. But nowadays we have a lot of advanced mechanisms, advanced methods to find out this hypoglycemia. So what are the strategies to prevent hypoglycemia? So monitoring with the SMBG is essential for insulin users. That is a standard protocol. But in today's world, we use CGM for most of the patient because it detects asymptomatic and nocturnal hypoglycemia very easily. And use of CGM reduces the episodes of severe hypoglycemia and admissions to hospital. And use of CGM in collaboration with advanced treatments, changes in the advanced treatments like use of long-acting insulin, you can improve the time in range in patients with type 1 or type 2 diabetes. And use of CGM enables proactive interventions. So you can have a clear picture of what is happening to the blood sugar levels of the patient. Whenever it is high, you can raise the dose of insulin prior to the rise. And when the blood sugar levels become low, you can reduce the dose of insulin or you can titrate the dose of oral hypoglycemic agents according to the blood sugar levels. And what are the key metrics for prevention of hypoglycemia? Using a CGM, you keep the time below the range, that is time below 70 milligrams per deciliter as 4% and time below 54 milligrams percentage as 1%. If you are aiming for this level, you can prevent hypoglycemia. And also the glycemic variability, that is the coefficient of glycemic variability, should be less than 36%. And you should keep on analyzing the trend arrows and the alerts in the CGM machine. So CGM alarms can be set to and it can be individualized to the patient, but generally low glucose alert in the range of 70 to 80 and urgent low glucose alert can be set in the range of 55 milligrams per deciliter. So nowadays we have CGM devices that can be connected to our mobile phone as well as your watch, so that whenever the blood sugar levels are very low, you can get an alert in the watch also. So previously we saw this watch, but this was a pictorial representation. This was a pictorial representation, but now today it has come to the reality. So what are the clinical outcomes of using the CGM? We have documented decreased incidence of severe hypoglycemia, lesser admissions to hospital. Cognitive safety has improved because repeated hypoglycemia, cognitive impairment is very, very common. And quality of life of our patients with insulin and other drugs have improved to a great with the use of CGM. So some practical tips to be followed in your day-to-day clinical practice. So you should ask about hypoglycemia at every visit. Some patients may ignore about the hypoglycemic symptoms like headache, weakness, all those things. And you ask the patient to check the blood sugar level whenever they feel weak, that could be hypoglycemia. And review medications each and every time. So sometimes you may be giving the prescription, but the patient may be taking different medications at different dosages or different combinations. If you are not having enough time to review the medication, ask your assistant or nursing staff or a diabetic educator to review the medications. And very common error among the insulin using patients are the insulin syringes. So you must have prescribed 40 IU insulin vial, but the patient will be using 100 IU syringe for that. So there should not be any mismatch between the insulin vial concentration and the syringe type. And sometimes patient used to take uh, pen devices, and sometimes they do not know how to operate the pen, and they take the insulin with the insulin syringe. So all those things has to be reviewed during the patient visit, and educate not only the patient, also the caregivers about hypoglycemia, and use this technology, particularly CGM, appropriately in all your patients. So the take-home message is hypoglycemia is largely preventable disease or disorder. Education about hypoglycemia to your patient and appropriate use of technology will provide a better outcome in your clinical practice. Again, individualization is the key. Don't aim for strict glycemic control in all your patients. Individualize the glycemic target depending on the patient features. Thank you one and all for your patient listening. If there are any questions, you can type in the chat box.
Thank you, Dr. Mahesh. You have beautifully highlighted about the hypoglycemia from the old textbook to old technology and the recent up to CGM. Of course, as you end, now DKA as well as hypoglycemia is totally preventable. Like we discussed earlier, while myself and Parandaman was in practicing early in Diabetes Hospital, so the facilities were remote, awareness also not there. So we do come across a lot of hypoglycemia as well as hyperglycemic episodes very often, very often. And especially post-hypoglycemic coma also quite common. The patient recover from hypoglycemia, but the damage occurred in the brain will not get recovered. So they will be in the ward for 2 weeks or 3 weeks. Then subsequently they develop bed sore and all. Then they subsequently die also after going home. So to that level we had a problem. Now after the arrival of SMBG, self-monitoring, those days self-monitoring, I was the only person having meter doing 92, 93 for the entire hospital. Now every patient has a self-monitoring system. Now the advanced technology, continuous glucose monitoring, also helping the physician as well as helping the patients. So you can identify hypo early at any time of the day by the patient and patient's caregivers. So totally preventable and correctable to the patient level or attenders level. If they come to the hospital also, as I told you earlier, 108 ambulance and the 108 call is helping them to prevent hypo. Before they come to the hospital, they are recovering the van itself, the ambulance itself. Sometimes some of the patients are arguing, shouting with the ambulance staffs also once they recover. So to that level, the technology, facility, awareness have improved. Despite that, we do come across hypoglycemia admission in the ward. And again, other component is earlier we were liberally using insulin and sulfonylurea because along with metformin, these two hypoglycemic agents only to treat diabetes up to the year 2000. If you upwardly titrate either insulin or sulfonylurea to control diabetes, almost 30 to 40% of the patient will develop hypoglycemia. Because they develop hypoglycemia, they stop treatment also. Because they may develop hypoglycemia, we also hesitate to upwardly titrate the dose also. So under treatment also will be there. Now, after the arrival of alpha glucosidase inhibitors, glitazone, gliptin, gliflozins, GLP-1 receptor analog, they are all non-sulfonylurea molecule, non-insulin molecule. They are beautifully helping us stably maintaining the glucose without hypoglycemia and without glycemic variability also. That way also we are now gifted for the past 20 years because of these newer molecules. And this CKD hypoglycemia also he told. So once the CKD starts, the elimination of endogenous insulin also through kidney. The endogenous insulin which was insufficient will become more sufficient once CKD develops. So they go for persistent prolonged hypoglycemia. Especially if you use long-acting sulfonylurea or long-acting insulin, once they enter into hypo, you may correct it in the emergency ward. After a few hours of correction, again they may enter into hypo. So to that level, the hypo used to give some problem for CKD patients. And of course, autonomic failure and hypo also is highlighted well. And, regarding this topic also, if audience have any questions or clarification or their own experience, we can share for some time. Over to Raj Kamal for questions.
Sir, we have only one question, sir. For how long of hypoglycemia duration patient would land up with neuroglycopenic symptoms? Will it be reversible or irreversible?
Yeah, it depends on the patient. See, we have seen a couple of patients with neuroglycopenic symptoms who landed up in coma. Almost all the patients are above 80. See, above 80, they live alone at home, no caretakers. The patient has taken insulin at night. Morning, the caretaker has gone, found the patient in coma, and brought to emergency. So we had a few number of patients like that. Almost all are elderly people. So I have never come across a hypoglycemic coma in middle-aged or around 60 years, all above 80. So we admitted those patients and we lost one or two patients because of severe irreversible coma, and two patients the patients recovered from the critical state, but still have some residual neurological deficit. They are not able to talk, they are not able to do their own work, they are wheelchair bound. So it all depends on
post-hypoglycemic sequelae. Post-hypoglycemic sequelae.
Yeah, post-hypoglycemic sequelae. It all depends on how soon the patient are brought to the hospital.
Okay, sir.
Minimum 15 minutes to maximum 30 minutes, the brain can tolerate.
As sir told, now with the availability of 108 ambulance and other ambulances, they go with 25% dextrose to the home and they give it at the home itself and then only bring it to the hospital. But that has to be alerted to the hospital. So elderly people who live alone, someone has to see the patient at the morning only. So it becomes very difficult.
No. In one of my cases, daughter-in-law is a teacher and the son is working somewhere in the bank. Aged people, about 70-year-old man and a 70-year-old lady, both are diabetic on 11-glutamate BD. This had happened in 92. So they have not taken the lunch. They slept in between. They have not taken the lunch, but morning dose of Dynil have been taken along with metformin. During sleep, they develop hypoglycemia. They have not opened their door for their grandchildren. They have not opened the door for daughter-in-law as well as son up to 7 o'clock evening. Then they broken the door and both are in coma. They brought to hospital and we are not in a position to help the patient because they are in coma for so many hours. They are in coma for so many hours. So such things are happening.
So these things can be now avoided with the help of this continuous glucose monitor. So the recent glucose monitor comes with mobile connectivity where the signal comes. Whenever the blood sugar goes less than 80, the mobile starts beeping. So some patients have started complaining, sir, summa அது கத்திக்கிட்டே இருக்கு சார் 80 போனாலே அப்படின்ட்டு. But it will be more useful for elderly people like more than 80.
250 போனாலும் கத்திக்கிட்டே.
Sir, I have one doubt, sir. Dr. Aditya here, sir.
Yes.
Sir, I had one patient, sir, who came post alcohol binge. He went into hypoglycemia. Then what happened is our house surgeon has given 25D without giving timing. And then patient went into Wernicke's encephalopathy. But in my other experiences, where when I worked in PHC, for few patients I have not given timing and I corrected 25D. But those patients have not developed the Wernicke's encephalopathy, alcohol binge also. Is there any subset or any difference?
You are right, doctor. You are right, very right. Because this encephalopathy will happen if you correct with 25% dextrose without thiamine, only in patients who have chronic alcohol intake. Okay, chronic alcohol intake. Chronic alcohol intake patients only develop this Wernicke's encephalopathy. So first episode of hypoglycemia because of binge alcohol, you give 25% extras without timing, nothing is going to happen.
And sometimes this is also happening. So they may be under the influence of alcohol. Simultaneously, they may have hypoglycemia also.
Yes, sir.
Even the family member themselves will miss it. So he is under the influence of alcohol. But unfortunately, he may be in the hypoglycemic coma. So they may not come to the hospital early. Such problems also happen. Now, all these things can be overcome now with the help of meters now. Meters and
Very
SLB.
true, sir.
So continuous glucose monitoring, everybody cannot afford or everybody cannot go for. Self-monitoring is helping. The meters are helping many patients.
Yeah, though we talk about continuous glucose monitoring, more than 90% of our patients are still on SMPG only. But we have to encourage frequent monitoring.
Yeah.
That's more
CGM
important.
will help us only for 15 days. They cannot wear continuously also.
Yes. So we use CGM only for high-risk patients, like patients on basal bolus insulin started newly, and type 1 diabetes who are started on basal bolus insulin newly, gestational diabetes, and the patient recently discharged from hospital after major surgeries or cardiac interventions. Apart from that, all other patients we advise only SMBG.
Sir, we have one more question, sir. Importance of infections and hypoglycemia.
See, generally, we come across a lot of infections related to lungs, lung abscess, tuberculosis, urosepsis, this pyelonephritis, and diabetic foot infections, and some skin infections. So these are the common infections which we come across. All these infections present with hyperglycemia, okay, because of the cytotoxins that are released from the bacteria that will increase the insulin resistance. Patient will present with hyperglycemia only. So intensive treatment with insulin can land up in hypoglycemia. There are certain infections where the patient comes with septicemia. Patient has long-standing diabetic foot, develops septicemia. Only then the patient will come with hypoglycemia because of septicemia. So that's very, very rare condition.
Again, gram-negative bacteremia also will cause hypoglycemia.
Yeah, that's what I told us, septicemia.
Gram-negative bacteremia.
Yeah, bacteremia and septicemia will land up in hypoglycemia.
Yes.
Sir, one case can I share, sir?
Yeah.
Aditya here, sir. Sir, recently in our hospital, sir, we had a patient, sir, one 40-year-old female, sir. She came with recurrent vomiting history, and her CBG was around 500. Then we thought, okay, this lady might come into DKA. We did ABG, sir. ABG was normal, and anion gap was also normal. Then we thought, okay, it might go into honk, and we thought we sent for ketones, which took some time. Then this lady was persistently vomiting. Okay, I started insulin infusion and everything I started, sir. Then still she had vomiting. Then I got, okay, why again we'll check for the pH, because somewhere I was getting that this could be DK. When I repeated the ABG, this time it showed the pH 7.2 with high anion gap. Like this is the, I think 1 or 2 times only I encountered where the patient initially had pH normal with high CBG. Then but symptoms started before. So like this presentations also, DK, have you seen in your massive practice, sir?
Yeah, you do come across.
Possible.
Before chronicity sets in, you are picking up the symptoms are developing much early.
Sir,
this is called acute hyperglycemia inducing vomiting. Then once you correct it immediately, so the vomiting will settle down. But all other parameters will get altered only after 6 hours or 12 hours. But setting in of acute hyperglycemia sometimes present with gastritis, vomiting, or even mild pancreatitis.
Then we gave IV fluids and we settled the patient, sir.
Yeah. Now it is easy to manage also.
Yes, sir. Yes, sir. Thank you, sir.
See, generally the vomiting is because of ketonemia only. So whenever a patient with type 1 diabetes or type 2 diabetes with uncontrolled hyperglycemia, like you tell 400, 500, develops vomiting, that vomiting is because of ketosis only. So the ketone level may not build up in the blood sugar, blood, but it will take some time to build up in the blood. Okay. So as sir told, the disease has some stages. So starts with ambulant ketosis, then goes for frank diabetic ketoacidosis. So it is ultimately our clinical decision. Okay.
After some time only the enzymes will get changed.
Yes, sir. Yes, sir. Thank you, sir. Thank you, sir.
Thank you, sir. That's all the questions. Over to you, Ranjit, sir.
Sir, thank you so much, sir.
So we have come to an end, sir.
Yes, you can go.
Oh, like Mahalakshmi or Ranjit?
So we have come to an end, sir.
Right.
Sir, I sincerely thank Dr. Panniselvam, sir, for being with us and making this, carrying out this session very lively and very elaborately, sir. Thank you so much, sir, for being with us. I thank Dr. Mahesh Babu, sir, and Dr. Parandaman, sir, for sharing their knowledge and sharing their experience in a very elaborate manner, sir. Even though we have attended so many classes, seminars, and on many DKA classes and hypoglycemia, at in the end of each classes, we will be learning new points in every classes. So that's what happened today also. Both of the speakers presented in their unique way. That was very applaudable, sir. I thank all the participants, sir, for their support, for their patience, and I request all the participants to stay connected with us for the next program also. I special thank the pharmaceuticals online platform wonderfully. On behalf of DKA, I thank one and all for making this session a grand success. Thank you and have a great day. Thank you.
Thank you. Thank you,
Thank you,
Dr.
sir. Thank you.
Ranjit.
Thank you,
For
sir.
the speaker, Kamal,
Thank you all.
Thank you, sir.
Aditya.
Thank you.
Mahesh, sir, thank you so much, sir. Super, sir.
Thank you.
Aditya, thank you.